Hello, my name is Lee Myers, and I'm a Doctorate of Nurse Practice graduate student at the University of Massachusetts Amherst. For my capstone project, I am introducing a toolkit for nurse practitioners and other providers that will disseminate the American Academy of Pediatrics and the Centers for Disease Control and Prevention's newest evidence-based practice guidelines on the diagnosis and management of mild traumatic brain injury among children, issued September 4th, 2018. A research toolkit is useful for this project as it is meant to provide evidence-based care that promotes quality health outcomes for individuals, families, communities, and healthcare systems. The CDC recommends using the term mild traumatic brain injury, mTBI, in place of the term concussion moving forward so there is consistency and no misinterpretation across stakeholders. Evidence suggests that there is variability in provider care, experience, and training, coupled with an explosion of previously published guideline consensus statements, has led to some uncertainty and inconsistency in the management of these injuries. According to the CDC, mTBI occurs in approximately 3.8 million people annually, with those numbers rising among children and adolescents, putting this population at risk for a syndrome that can last weeks to months and affects cognitive function, memory, sleep, and can be physically exhausting. As the number of emergency department visits for mTBI increases, so does the demand for primary care providers competent in the evaluation and management of mTBI during both the initial presentation and clinical follow-up. Studies show that adolescents and children may require a longer recovery time related to the continuous growth process and more fragile condition of the brain. Differences in pediatric anatomy and physiology, such as disproportionately large head compared with body size, immature neurologic function, and inability to recognize or avoid injury because of age, developmental stage, predisposes children to high risk for injury. Sports-related mTBI is an important topic in nearly all sports and at all levels for children and adolescents. Effective management can aid in recovery and potentially reduce the risk of long-term symptoms and complications of sequela. Because many of these symptoms often interfere with school, social life, family relationships, and athletics, and mTBI may affect the emotional well-being of the injured athlete. Because every mTBI has its own unique trajectory and severity of symptoms, individualized management is appropriate. The reduction, not necessary elimination, of physical and cognitive activity is a mainstay of treatment. A full return to activity and sports participation is accomplished by using a stepwise program while evaluating for a return of symptoms. An understanding of prolonged symptoms and complications will help the provider know when to refer to a specialist. For example, youth athletes that present with vestibular ocular dysfunction such as dizziness or balance problems may require referral to a physiatrist for vestibular rehabilitation. Patients with worsening sleep problem require education on sleep hygiene and possibly referral to a sleep specialist if their symptoms do not resolve. Additionally, youth athletes with cognitive impairment that is baseline or new need treatment directed at the etiology, and neuropsychological evaluation is appropriate. In recent years, there have been a series of varying concussion laws passed throughout the United States, modeled after the landmark Washington State Zachary Lystedt law. These laws have been enacted to improve recognition and management of sports-related mTBI with three common foundational principles that include recognition, education, sports removal, and return to play. The laws are also explicit that healthcare providers participate in required trainings to diagnose and manage mTBI in youth sports. Heads Up to Providers, Healthcare Providers is a free online training developed by the CDC and the American Academy of Pediatrics and may be required by individual state law. The goal of the training is to provide an overview of evidence-based recommendations as outlined in the CDC practice guideline to equip healthcare providers with practical strategies to integrate these recommendations into clinical practice. I urge everyone watching this presentation today to utilize the free resource which offers 2 CEUs for participating and also may be a requirement of your respective state law to provide medical clearance. mTBI sustained during sports, even with a helmeted head, puts youth athletes at risk for potentially detrimental consequences such as second impact syndrome. This syndrome can result in devastating consequences such as collapse, death, permanent neurological damage, respiratory failure, and loss of consciousness. Since second impact syndrome can result from a second injury before complete symptom resolution from the initial mTBI, it is imperative for practitioners to ensure adequate recovery and prevent the athlete from returning to play prematurely. Furthermore, repetitive mTBIs over time has been linked to conditions such as depression, mild cognitive impairment, and prolonged recovery from future mTBIs, and potentially chronic traumatic encephalopathy. Having management tools readily available to diagnose and manage pediatric sports-related mTBI in your office can help to expedite the assessment, diagnosis, and management process. Many children who have sustained a serious mTBI while partaking in sports will be triaged to the ED by their athletic coaches. However, the vast majority of youth athletes will present to a primary care facility. It is essential that clinicians have the knowledge and expertise to not only assess and diagnose these children, but have the ability to provide appropriate anticipatory guidance to return these children to play and learn or refer as needed to specialists. The pre-participation physical should include the pre-morbid health histories of these children and will be an invaluable resource when differentiating persistent symptoms. Additionally, the pre-participation physical exam is a perfect time to educate the youth athlete and their parents on prevention of mTBI, such as wearing properly fitted headgear, helmets, and mouth guards, for example. The CDC guidelines offer 19 sets of clinical recommendations that cover diagnosis, prognosis, management, and treatment. The guideline is applicable to healthcare providers in all practice settings and highlights specific actions healthcare providers can take to help youth athletes and their parents and caregivers. These include 5 key practice-changing recommendations. Number 1, do not routinely image pediatric patients to diagnose mTBI. Clinical evaluation of the child with possible mTBI includes balancing the likelihood of possible tragic complications of a more severe injury against the risks associated with head CT, such as radiation exposure and concomitant sedation imaging. If the provider suspects intracranial injury, then head CT is a preferred diagnostic tool in acute care settings, and the family should be counseled as such. Number 2, use validated age-appropriate symptom scales or decision rules to diagnose mTBI. Examples of validated scales include, but aren't limited to, post-concussion symptom scale, health and behavior inventory, post-concussion symptom inventory, acute concussion evaluation, offered at the CDC website in the office and emergency department versions, and there are an array of others. Number 3, assess for risk factors for prolonged recovery, including history of mTBI or other brain injury, severe symptom presentation immediately after the injury, and personal characteristics and family histories, such as learning difficulties and family and social stressors, because all of these can impact recovery and outcomes. This is why it is important to have a pre-participation physical on file with pre-morbid conditions clearly documented. Number 4, provide patients and their parents and caregivers with instructions on returning to activity customized to their symptoms. And 5, lastly, counsel patients and their parents and caregivers to return gradually to non-sports activities after no more than 2 to 3 days of rests. The provider should offer clear instructions, preferably written, verbal and written, that will explain red flags to monitor and the important aspects of the stepwise approach. This concludes the presentation of introduction of the toolkit. Please follow the instructions to complete the post-test you will soon receive in your emails. Lastly, I want to thank you for your participation. It is my hope that nurse practitioners and other providers that may be watching this presentation will have the knowledge, resources, and confidence to make evidence-based clinical decisions and have improved management strategies when caring for the pediatric athlete with the mTBI in their respective practice settings.